Good morning, ladies and gentlemen. This lecture is about understanding dry eyes. Dry eye disease affects millions of people worldwide. It not only has a considerable negative impact on the quality of life of patients who are affected by it, but it also imposes a significant socioeconomic burden. It is usually present in a mild grade in most of the population at one time or the other, since it has been found to be a part of the normal aging process. But it can get worse by any long term use of topical medication or any ocular surgery, and then it will present with symptoms that are totally unrelated to the surgery itself in the post op period. So, this will not only frustrate the treating ophthalmologist but also the patient. Every ophthalmologist will come across such patients in clinics, hence, it's extremely important to understand the etiology and the basic pathophysiology of dry eye disease so that the patients can be managed efficiently. Till 2006, not much was known about this very common problem. Then the dry eye workshop was formed in US in 2006, and for the first time dry eye disease was defined. In 2015, the Tear Film and Ocular Surface Society launched the dry eye workshop in order to advance the research, knowledge, and educational aspects of the tear film and ocular surface, and an updated definition and classification of dry eye disease was presented. Furthermore, the epidemiology, pathophysiology, and the clinical impact of this disorder was presented in detail, and recommendations were developed regarding its diagnosis, management, and therapy. In this lecture, I shall discuss these one by one. So, in 2015, the dry eye disease was defined as a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film, resulting in its hyperosmolarity. The hyperosmolar tear film, in turn, results in inflammation of the ocular surface, its damage, along with neurosensory abnormalities, which are responsible for the varied ocular symptoms. The multifactorial nature and elusive etiology makes it a very challenging problem to be treated by ophthalmologists. But I'm sure this lecture will offer a better understanding, and I have tried my best to simplify things for you. In simple terms, an eye becomes dry when not enough moisture is present on the cornea to maintain its clarity, transparency, and to make it a smooth, polished surface that is required for having a perfect vision. The concept of ocular surface, the detailed structure of the cornea, and the physiology of the normal tear film has been fully explained in the previous lecture. If you really want to understand the pathophysiology of dry eyes, kindly listen to the previous lecture first and then this one. Normally, a balance exists between the production of all three components of the tear film and the loss of tears or aqueous component by the process of evaporation into the atmosphere, and the drainage of any excess amount of aqueous by the lacrimal drainage apparatus. As long as this balance is maintained, the ocular surface will remain moist even at extremes of temperature. The blink mechanism and the concept of lacrimal functional unit has been fully explained in the previous. But to summarize how the lacrimal functional unit operates, as soon as a dry spot appears on the cornea or the osmolarity of the tear film increases, The receptors, which are present on the epithelial cells of both the conjunctiva and the cornea, are stimulated, and they generate neural signals that are passed to the brain. Brain then orders the parasympathetic nerves to help coordinate ocular surface wetting. So it signals in the form of protein molecules which have been recently isolated as lecithin and about 100 other protein molecules are passed to the main and the accessory lacrimal glands, goblet cells, and the meibomian glands so as to restore the tear film and provide protection, lubrication, and an environment for corneal epithelial cell renewal. If any portion of this functional unit is compromised, lacrimal gland support to the ocular surface is impeded. The basic mechanism involved in the production of a dry eye is a reduced amount of aqueous in the tear film that either by reduced production by the glands or an excessive evaporation. And this results in increase in concentration of solutes or salts in the tear film, thereby increasing its osmolarity from the normal level of 300 milliosmoles per liter to as high as about 1000 milliosmoles or even more. This effect is exaggerated in extremes of temperature and low humidity as the evaporative loss increases. And in such patients, the severity of their symptoms increases in hot weather. The hyperosmolar film, in turn, results in two processes. The tear film hyperosmolarity triggers a cascade of signaling events within the corneal surface epithelial cells, resulting in the release of chemical inflammatory mediators like cytokines, chemokines, and these interfere with nerve signals and functioning of the lacrimal functional unit as a whole. As a result, the secretion of aqueous, lipid, and mucin all are reduced. The second effect of this hyperosmolar tear film is that there is drying of the surface epithelial cells. And these dried cells release increased amounts of cytokines and matrix metalloproteinases. And these enzymes further damage the conjunctival goblet cells and corneal epithelial cells, as well as the mucin glycocalyx complex. Loss of this important layer makes the cornea hydrophobic, initially at a few places, but as the disease progresses, the whole cornea is affected, which is apparent as the characteristic punctate epitheliopathy and a reduced tear film breakup time. The breakup of tear film exacerbates and amplifies the tear osmolarity and completes the vicious circle that leads to increasing ocular surface damage and further inflammation. Ultimately, this results in a self-perpetuation of the disease. Inflammation causes sensitization of pain receptors and a chronic neuropathic pain, which is noted in few patients with dry eyes. A third effect of this ocular surface inflammation is the release of cytokines, which recruit T lymphocytes that infiltrate the lacrimal glands and the ocular surface. And these activated T cells further release more inflammatory mediators, which reinforce the damage to the ocular surface and further reduce the production of aqueous. Dry eye disease has been classified according to its pathophysiology into two main types: the purely aqueous deficient dry eye, in which not enough aqueous is being produced by the lacrimal and the accessory lacrimal glands. This affects only about 10% of patients who present with dry eyes. The second type is an evaporative dry eye, which is caused by a faulty or reduced lipid layer, resulting in an over evaporation of aqueous. This occurs as a dysfunction of meibomian glands. With age, there is an increase in meibomian gland dropout due to a fall in bioavailable androgens as a result of the menopausal process. Other contributing factors for meibomian gland dysfunction is treatment for acne vulgaris in young age, anti-glaucoma drugs. They also lead to meibomian gland dysfunction, and they influence the morphology, survival, and proliferative capacity. In addition, ocular cicatricial diseases like trachoma, pemphigoid, they all promote the loss of meibomian glands. However, the most common form of dry eye disease is the mixed variety, which is noted in 80% of the population presenting with dry eye disease, and it is due to both over evaporation plus aqueous deficiency. In aqueous deficient dry eye, the onset of early tear film breakup may add a secondary evaporative element to the dry eye disease. But whether it's an evaporative or an aqueous deficient dry eye, in both, the underlying pathogenic mechanism is an hyperosmolar tear film, which initiates ocular surface inflammation. In few patients, especially Steven-Johnson syndrome, there is loss of goblet cells, seen also in chemical injuries, and the loss of goblet cells result in mucin deficiency and a poor wetting of the ocular surface, even though there is an adequate tear production. Dry eye disease can be seen in at any age. It's more prevalent in the elderly, but even in the young, it can be seen. The patients will present with variety of symptoms like redness, watering, irritability, particularly after prolonged reading or looking or staring at digital screens. Then it can result in extreme symptoms of blepharospasm. The pain that is noted is the result of hyperosmolarity stimulating the corneal nerve endings, and they lead to discomfort, increase in the blink rate, and a compensatory reflex increase in tear production, resulting in a watery eye. And this compensatory secretion is more likely in an evaporative dry eye in which the lacrimal gland function is potentially normal. So, continuing on with the pathophysiology of dry eye disease, the chronic ocular surface inflammation has another important effect on the ocular surface. It results in loss of nerve growth factors and damage to the existing subbasal nerve plexus. This is evidenced on confocal imaging as a decrease in nerve fiber density, their tortuosity, and bead-like formation called microneuromas, as is shown in this slide. The reduced number of subbasal nerves result in reduced level of corneal sensation, and it correlates with findings of the Schirmer's test. The injured corneal nerves and microneuromas exhibit increased sensitivity to chemical and mechanical stimuli, resulting in hyperalgesia or dysesthesia or a severe neuropathic pain that is perceived by the patient as chronic irritation, dryness, foreign body feeling, or even a severe ocular pain. The discrepancy between increase in patient symptoms in the presence of reduced corneal sensation. is explained by the fact that the initial injury of corneal nerve endings due to the inflammatory process is followed by an increased excitability in regenerating sprouting nerve endings. As I mentioned in the beginning of the lecture, that a mild form of dry eye disease is extremely prevalent in the normal population and they never complain of any problem till their existing disease is aggravated by predisposing factors, and these precipitating or aggravating factors need to be identified and treated. So, most important on top of the list is the work environment. Working for long hours in air conditioned rooms or offices creates a very dry environment, which enhances the evaporation of aqueous. This exact effect is exaggerated by staring at digital screens or reading for long hours. As the interval between blinks increases, the excessive evaporation of aqueous occurs. This makes the tear film hyperosmolar and initiates ocular surface inflammation and dry eyes, which is manifested as irritation, redness, watering, and a feeling of discomfort after doing prolonged near work. And this is termed as the computer vision syndrome. Another important predisposing factor is ocular surgery. A pre existing mild to moderate tear film instability generally exists in the elderly population due to androgen deficiency, and it generally goes unnoticed by the ophthalmic surgeon unless it is specifically looked for. The chemical toxicity of topical medications, particularly the preservatives, which are used preoperatively, intraoperatively, and then during the post-op period, aggravates the coexistent meibomian gland dysfunction, which is present in almost every elderly person. The added surgical trauma destroys the nerve plexus at the incision site and reduces the corneal sensitivity and tear film breakup time. Moreover, the mechanical injury from surgical instrumentation further aggravates the ocular surface inflammation, mainly at the site of corneal incision or sutures, and due to continuous suture irritation in the post-op period, filaments may form in the late post-op period at that site. It takes a long time for the composition and production of the tear film to recover post-op. The other important factor in inducing post-op dry eye is LASIK or PRK. Within the first month after LASIK, the number of subbasal and stromal nerve fiber bundles are reduced by 90% as compared to the pre-op values because of cutting of the flap. This markedly reduces corneal sensation and the recovery of which may even take 6 months. However, the nerve density remains less than half even at 12 months. The nerve regeneration appears to remain incomplete even at 5 years. Interestingly, a study comparing corneal wound healing and nerve regeneration showed no difference between flaps created with femtocytokine laser as compared to the mechanical microkeratome. A reduction in neurotrophic stimuli in severe neuropathy may induce a thin epithelium, recurrent erosions, especially in diabetic patients. The problems after PRK are less pronounced. The subbasal nerve plexus is undetectable in the treatment area of post PRK corneas. However, these nerves slowly regenerate and return to a normal density within 2 years. Recovery of corneal sensitivity after PRK starts at 4 to 6 weeks after surgery. and appears to be completed within 6 to 12 months of surgery. Dry eye disease is highly prevalent in chronic diabetics. The incidence of dry eye is correlated with the level of glycated hemoglobin. The higher the level of hemoglobin A1C, the greater is the incidence of dry eyes. It is seen more in patients with diabetic retinopathy or clinically significant macular edema. And this is because of the following mechanisms. Number one, the hyperglycemia results in increased tear film osmolarity and an increase in ocular surface inflammation. Number two, the sorbitol that accumulates in epithelial cells and leads to cell edema and dysfunction, which ultimately damages the lacrimal gland structure, and its dysfunction further reduces aqueous secretion. It has a similar effect on meibomian glands. Number three, the neuropathy and the microangiopathy further reduces the secretion of aqueous and meibum. Then the autonomic neuropathy reduces corneal sensitivity and lacrimal functional unit dysfunction. Corneal and conjunctival epithelial damage with reduced mucin secretion. Hence, all three layers of the tear film are affected in diabetics. Smoking is another important factor that needs to be controlled. Smoke is an irritant to the eyes, and cigarette smoking worsens the symptoms of redness, grittiness, and watering in dry eye patients and increases the ocular surface inflammation. Vitamin A deficiency interferes with functioning of conjunctival goblet cells and loss of ocular surface mucins, thereby making the cornea hydrophobic. Vitamin D has an immunomodulatory role in innate and adaptive immunity. Vitamin D supplementation promotes the secretion of aqueous meibum and reduces the meibomian gland dysfunction. It reduces the inflammation of ocular surface and of the lid margin, thereby improving the stability of the tear film. Another important role of vitamin D is in reducing the neuropathic pain. It improves sleep and quality of life of these patients. Prolonged wearing of contact lenses causes harmful effects on the ocular surface. When the contact lens is worn, it splits up the precorneal tear film into two portions, a pre-lens tear film and the post-lens tear film. The splitting up of the tear film results in hypoxia of the cornea, and that corneal hypoxia is manifested in the form of microcysts. These microcysts are due to the swelling of the basal epithelium, and more than 10 microcysts indicate severe hypoxia. This hypoxic injury is more pronounced in people who are wearing contact lenses overnight and wearing them for weeks or months. People who take the contact lenses out at night, the effect of hypoxia is less. Similarly, the contact lens is an irritant to the eye, and especially if it is not washed, the chemicals are not washed properly, so they aggravate the already present dry eye. Prolonged use of topical medication increases the toxicity not only from the drug formulation itself, but also from the preservatives which have been added to enhance the shelf life and drug penetration. The mechanisms involved are an acute allergy or direct toxicity or inflammation. The most frequently used preservative is benzalkonium chloride, which is a quaternary ammonium compound, and it is weakly allergenic but highly toxic. depending upon its concentration used. It has a surfactant action that breaks up or dissolves the tight junctions between the corneal epithelial cells and the apical zonula occludens in both the corneal as well as the conjunctival epithelium. Thereby, it increases the space between epithelial cells to enhance drug penetration. It also causes conjunctival squamous metaplasia and apoptosis, loss of goblet cells, loss of epithelial microvillar brush border, and the glycocalyx mucin, resulting in an instability or breakdown of the tear film. Its detergent effect disrupts the lipid layer of the tear film, resulting in an enhanced evaporation of the aqueous component with resultant corneal dryness. For this reason, it is not used in combination with topical anesthetic agents. Another effect is to stimulate conjunctival fibrosis, and it is a potential risk of failure for glaucoma surgery. Its toxicity is direct as well as indirect. The direct effect is dose and time dependent, manifested as a subclinical inflammatory response, as a foreign body or a burning sensation, while the indirect cytotoxicity is mediated as a delayed type 4 hypersensitive reaction as eczema or blepharitis. Then others, the systemic medications like diuretics, antihistamines, and antidepressants, they reduce the production of aqueous and can alter the balance between aqueous and mucin in the tear film. As I mentioned earlier, dry eye is prevalent in almost every elderly person, and this is because of androgen deficiency. With age, the hormonal imbalance ensues. Androgens are trophic hormones for lacrimal and meibomian glands as well as the conjunctival epithelium. Androgens also are potent anti inflammatory agents and they suppress the lymphocytic infiltration of lacrimal glands. So, androgen deficiency with age or by the use of medications or in patients with prostatic cancer, the deficiency of androgens results in reduced aqueous, less lipids, and more evaporation of aqueous with resultant hyperosmolar tears and more cytokine production by lymphocytic infiltration and enhanced ocular surface inflammation. They are also known to prevent keratinization of ducts and prevent the blockage of meibomian ducts. So, androgen deficiency with aging process results in enhanced ocular surface inflammation and dry eyes. Any chronic ocular surface inflammatory condition like vernal keratoconjunctivitis, allergic conjunctivitis, or any prolonged condition causing a red eye will lead to dry eyes ultimately. The corneal limbal tissue is vulnerable to inflammatory mediators, antibodies, and complement released by eosinophils and lymphocytes present in the perilimbal vascular arcade, especially in the VKC. The perilimbal swelling in VKC results in tear film instability and formation of filaments. Additionally, the autoimmune disease process affects the secretion of all the three glands involved in tear production, tear film formation, resulting in a severe form of dry eyes. Also, the topical medications which are used long term to control these conditions have an additional toxicity. Formation of filaments is noted in any form of chronic dry eyes. Filamentary keratitis is actually a severe form of dry eye. Normally, mucin molecules are floating freely in the aqueous part of the tear film. But as the aqueous amount of aqueous in the tear film reduces, the amount of free mucins increases. These mucins settle down in the lower conjunctival fornix and the adjacent molecules they join together, forming disulfide bonds and result in the formation of mucin threads. The hyperosmolar tears lead to sloughing of the desiccated corneal surface epithelial cells and produce epithelial defects, which are high energy pits, and they promote the adherence of these mucus strands to the areas of denuded corneal epithelium. The corneal epithelium grows around a filament to form a large filament. Thus, an increased ratio of mucins to aqueous is necessary for the formation of filaments. This occurs if there is a decreased production or an increased evaporation of aqueous, or there is an increased production of mucin per se. A damage to the basal epithelial cells or the epithelial basement membrane promotes the adherence of these altered mucins and filament formation. Filaments are gelatinous in nature and they consist of a central core of desquamated corneal epithelial cells surrounded by degenerating conjunctival epithelial cells and entwined in a thick layer of mucin. They can vary in size from 0.5 millimeter to as long as 10 millimeters, and being strongly adherent at one end to the basement membrane of the dried epithelial cells, while the other end is free and floating in the aqueous. They do not stain with fluorescein but do take up rose bengal and lissamine green. With each blink, the vertical friction occurs between the filaments and the upper lid. As a result, this pull causes further shearing of corneal epithelium and breaking down of intact basal membrane, resulting in enhancement of ocular surface inflammation and severe pain. So, to manage filamentary keratitis, the treatment needs to be targeted towards three important factors: to find and treat the underlying cause, to treat the associated ocular surface inflammation and prevent further epithelial degradation, and to treat the filaments by not by removing them but by dissolving them with acetylcysteine. So, with all this background knowledge, I'm sure you'll be able to diagnose dry eyes. Any patient presenting with irritable eyes, watery, red eyes, or blepharospasm, you have to ask yourself, is this really a dry eye syndrome? Then you have to look for an underlying etiology, whether it is evaporative loss, aqueous deficient, or is it a mixed variety. Then you need to look for a general cause in that patient and any local ocular pathology. Then, by history and by examination, you have to find aggravating factors and list them. Unless these aggravating factors are removed, you cannot efficiently manage dry eye patient. You need to know about certain diagnostic tests, the common tests that identify which layer of the tear film is deficient, and then there should be a proper management approach with grading of the initial severity of dry eye and then a stepwise management. The management of dry eye disease is complicated due to its multifactorial etiology. So, expanding upon the simple belief that diagnosis precedes therapy means that the clinician must make their best efforts to identify the degree to which evaporative, aqueous deficient, or other ocular surface conditions are contributing to the patient's presentation. This aspect of determining the major causative factors behind the dry eye disease is critical to appropriate management. So, a detailed history needs to be taken regarding the duration and severity of symptoms. Any systemic illness like arthritis, thyroid dysfunction, psoriasis, diabetes, or any other autoimmune disorder. Then, ocular allergies, recent or past ocular surgery, and a detailed list of all topical and systemic medications being used by the patient need to be noted. Then, the time spent on digital screens per day, patient's occupation and work environment, and smoking need to be noted. Since there are three layers of the tear film, there are three important tests to find out which layer is deficient primarily. Looking for local ocular pathology like anterior blepharitis, trichitis, trachoma, or demodex infection is important to note and to treat. Similarly, assessing the grade and severity of meibomian gland dysfunction is very important to note at initial visit, and then specific therapy initiated to correct it. The details of meibomian gland dysfunction are present in the review paper, which is also included in the chronicle. While the patient is sitting on the slit lamp, noting the level of the lower tear meniscus and the completeness of the blink. If the blinking mechanism is not complete or faulty, then the tear film will not spread on the cornea, as in this patient with the facial palsy and the other one with the cicatricial ectropion. So the cause has to be treated in addition to treating the dry. The red eye and the cicatricial ectropion in this patient has been managed surgically by a lateral tarsal strip procedure in addition to giving the dry eye therapy. So, the clinical assessment of dry eye patients involves a subjective assessment in the form of ocular surface disease index scoring. The patients are asked to fill in a survey, which is a 12 questionnaire survey, and they grade the severity of their symptoms. The clinician then calculates the ocular surface disease index score at the initial presentation, and then after institution of therapy at each follow-up visit to note how much is the improvement in patient symptoms with the management offered. A detailed ophthalmic examination is then performed in order to assess the underlying cause of the patient's problems and to grade the severity of dry eye disease before initiating the therapy. Facial appearance regarding brow droop, frequency of blinking, blepharospasm, dermatochalasis, position and contour of the eyelids is noted. While the patient is on slit lamp, a systematic assessment is made of the completeness of the blink, presence or absence of meibomian gland dysfunction by looking at the lid margin by thickening, telangiectasia, hyperemia, keratinization, or frothing at the angles, then noting the quality of meibum and the ease with which it can be expressed by pressing onto the lower lid margin with a finger or a cotton tip applicator. Then the position of the meibomian gland duct orifices, their clogging or notching, which indicates absence, and the presence or absence of distichiasis. The lower tear meniscus height is measured and its clarity noted. The presence of corneal filaments, their number or site is noted. Next, the tear film breakup time is measured without instilling any anesthetic drops. And then the fluorescein staining score. By noting the epithelial punctate staining of the conjunctiva or the cornea with fluorescein, presence of any corneal epithelial defect, scarring, or pannus. This slide shows the tear meniscus height, in which the slit lamp beam is narrowed and the height noted at initial visit and then later at each follow. This slide shows the tear film breakup time. The normal fluorescence from one blink to the next should be more than 10 seconds, and it indicates no evaporative loss. But in the other slide, the dark islands, the black areas appear in the fluorescent tear film, and these black islands indicate areas where the tear film has broken up due to excessive evaporation of aqueous, so the lipid is mixing up and splitting up, uh, appearing up as dark areas. The pattern and extent of corneal staining with fluorescein is noted. An inferior corneal staining next to the inferior limbus indicates meibomitis, where the irritant polar lipids in the meibum they irritate the cornea and the inferior conjunctiva, leading to inferior staining. An evaporative dry eye results in loss of aqueous on the most exposed central part of the cornea and hence staining in the most central part of the cornea or the limbal conjunctiva. Then the fluorescein staining score is measured according to the zones, the nasal temporal conjunctiva or the cornea being affected, and the scale is 0 to 3, where 0 no staining, the 1 is grade 1, where only there are few separated staining spots in that zone, or 2 where there are many separated spots, and 3 where there is an area of confluence staining, and maximum score is 9. So this fluorescein staining score is also calculated and noted in the clinical notes at each visit to assess improvement in. Schirmer's test need to be done with the anesthetic drops in order to assess the basal secretion of aqueous. And the prerequisites for the Schirmer's test are given in detail in the video which is posted on the Chronicle, and they have to be followed at each follow-up. This slide shows the image of meibomian glands, either taken by a lippy view or by a red-free camera. And in the bottom slide, it indicates how many meibomian glands have been dropped out, which shown with empty space. Before initiating the therapy for dry eyes, the severity of symptoms and signs need to be graded to the level of severity of the dry eye into 1, 2, 3, 4, 1 being mild, level 2 being moderate, and 3 and 4 being severe dry eyes, because the management protocol is according to that. The ultimate aim of dry eye management is to restore the homeostasis of the ocular surface and the tear film through breaking the vicious cycle of the disease. While certain treatments may be specifically indicated for one particular aspect of an individual's condition, a number of therapies might be appropriately recommended in order to treat the multiple aspects of a patient's presentation. So, while aiming to identify and treat the primary source of the disease, the management is typically aimed at instability of the tear film, with an extremely important contribution of meibomian gland dysfunction. So, the latest International Dry Eye Workshop 2 report, published in 2017, has emphasized the use of stepped care logarithm Treatment is planned according to disease severity. So, at first visit, the severity of dry eye disease has to be graded according to which level it is, and then the management is instituted. As I mentioned, the aim of therapy is to correct the instability of the tear film and to render the dry hydrophobic ocular surface hydrophilic. And the steps to do it is to eliminate the etiological factor as well as the aggravating factors, to re-establish the tear film, and then immune inhibition therapy to control the ocular surface inflammation and to maintain moisture in the eyes and other support measures. Before you start any therapy to the patient, you should remember this slide that rainfall cannot make a rock wet. So, lubricants alone will not make the hydrophobic cornea wet. Unless and until the ocular surface inflammation is controlled and the cornea is rendered hydrophilic or water loving, no matter how much lubricants you instill into the eye, they will be washed out of the eye without having any beneficial effect on the cornea and the ocular surface. Once the disease has been graded according to level of severity, the treatment of level 1 or the step 1 includes alteration of the local environment, education of the patient, dietary modifications including oral essential fatty acid supplements, identification and potential elimination of offending systemic and topical medications, addition of lubricants of various types, and treating the meibomian gland dysfunction, lid hygiene, and warm compresses. Humidifying ambient air, avoiding air drafts in the offices, and changing the airflow at work or at home and in the car may be helpful. A study has shown association between happiness and dry eye disease, suggesting the presence of psychosocial factors. So, if the treatment in the first step are insufficient, then the second level is instituted. These are the various lifestyle modifications that can be done. So, it's important to take a 5-minute break after every 40 to 45 minutes of close work, and sun protection when going out with glasses. A balanced diet with hydration is very important. Exercising the lids, that is squeezing the eyelids, improves the circulation and flow of meibum. So that needs to be done at least 20 times in the morning and 20 times in the evening. A few words regarding the lubricants: that the carboxymethylcellulose lubricants have improved ocular surface retention and promote epithelial proliferation. On the other hand, the sodium hyaluronate preparations are similar to the extracellular matrix in the cornea, and they play an important role in wound healing, inflammation, and in addition to doing the eyelid exercises in the form of squeezing both lids together at least 10-20 times in the morning and in the evening to improve the flow of meibum, hot fomentation is very important to melt the thick meibum, the altered meibum, and that hot fomentation can be done either with hot warm towels, wet towels, which have been warmed in the microwave, or soaked in hot water and then applied to the closed eyelids, or in the form of hot masks which have beads in them that can be placed in heated in the microwave for 10 to 20 seconds and placed on the eyes, or by LipiFlow, which is an expensive technique. If patient symptoms do not improve by the simple lifestyle modifications and level 1 therapy, the patient is reviewed after 1 month. Then the level 2 therapy has to be instituted, in which the tear film breakup time and Schirmer's have not improved beyond 10. Then addition of anti-inflammatory therapy is a must. Any patient with initial presentation with a level 2 dry eye disease with Schirmer's less than 10 and the tear film breakup time less than 10 has to be given anti-inflammatory therapy in the form of either cyclosporin eye drops 0.5 to 0.75% twice a day or tacrolimus ointment. These are the mainstay of therapy of dry eye disease in addition to the lubricants. Then tetracyclines for the meibomian gland dysfunction. Acetylcysteine has been known to improve the meibomian gland secretion and the goblet cell functioning, as well as they reduce the ocular inflammation, and they melt the corneal filaments without doing any harmful effect. Diclofenac sodium to reduce ocular pain, as well as it has an ocular surface anti-inflammatory effect. And omega-3 fatty acids have known to not any proper proven beneficial effect, as they have to be taken in huge amounts as oral supplements. Punctal plug should not be introduced into the punctae at this stage, as till the ocular surface inflammation has been controlled. If all the inflammatory products are retained in the eye, they will only worsen this inflammation. Therefore, punctal plugs should be avoided till the ocular surface inflammation has been fully taken care of by anti-inflammatory therapy. So, if there is a Demodex infection, then it should be treated with tree tree oil. Then, non-glucocorticoid immunomodulators like cyclosporin and tacrolimus. They are calcineurin inhibitors, and they specifically block the activation and proliferation of T cells and reduce the inflammatory mediators. They have no side effects on prolonged use, unlike the topical steroids, and they have extremely beneficial effect. The only problem is slight stinging or burning on institution, but the patients can be made to be compliant if they are told that they are free of side effects and they are extremely useful on long-term use. Oral erythromycin or azithromycin need to be given, or oral tetracycline in low dose for chronic meibomian gland dysfunction. Secretagogues and stimulants to improve aqueous production have been tried, but unfortunately they are not available here. Topical testosterone and intranasal neurostimulation have been also tried to improve aqueous production. If, in spite of all this therapy, the patient fails to improve, then the level 3 therapy has to be instituted in the form of especially autologous serum. Autologous serum is a very important mode of therapy, and that has to be instituted if at presentation the patient has a severe form of dry. Full detail regarding its preparation and dispensing is present on a paper in the Chronicle, so you should go through it. Just to summarize, it has got epitheliotropic factors, nerve growth factor, then it is immunogenic, and it improves the ocular surface healing very quickly because of its nutritional molecules as well. So it is not only a lubricant, but provides nutrition and growth factors for ocular surface reepithelization, and it is preservative free, and it has multiple uses. The aloe serum eye drops can be made in and prescribed for patients who in whom their own blood cannot be drawn. They can be The blood can be drawn from a parent or a brother or a sister, and the serum eye drops prepared. And one full blood donation produces about 150 bottles with a shelf life of 12 months from the date of donation. The level 4 dry eye disease is an extremely severe disease with totally eroded corneal surface and scarring with symblepharon, and it may need systemic immunosuppression along with surgery in the form of amniotic membrane graft, a mucous membrane graft, or corneal grafting. Patient follow-up is very important. It's mandatory to note the subjective improvement in the form of OSDI score at each visit, to note how beneficial your therapy is and whether you need to add something else to your therapy. Then you have to check the status of lid margins, meibum, cornea, tear meniscus height, and then do these tests at each visit. That is the tear film breakup time, corneal conjunctival staining, and the fluorescein staining score, and Schirmer's test to gauge the efficacy of therapy. So, to summarize, the treatment of dry eye disease remains something of an art. The treatment needs to be tailored according to the severity of patient symptoms and the signs at each visit. All it has to be remembered that the tear film is made up of three layers. So the three basic underlying causes has to be found out and treated. In addition, the underlying aggravating factors need to be removed, and most important, to render the inflamed hydrophobic corneal surface hydrophilic by addition of anti-inflammatory therapy as early as at level 1 of severity. These patients are extremely depressed and unhappy because of the chronicity of disease and inability of the ophthalmologist to recognize the severity of their symptoms. So help them. Make your patients happy and useful members of the society. Thank you very much for your patience and for listening to this lecture. If you have any queries, please post your comments. All that has been explained in this lecture is also given in various components of the chronicle. You can go through various papers, and any comments would be welcome. Thank you very much.